So let's please welcome Dr. Whaley.
Thank you very much for having me. I am a pediatrician by training. Worked my way into sleep medicine because the sleep medicine center was across the hall, and Carl Smoot decided it'd be a great idea if I did sleep medicine. And so he ran the UP Sleep Disorders Center and kind of schemed to show me what was done on the other side of the hall, allowed me admitting privileges to his lab, and before you knew it, I was hooked and interested. And so I credit Carl Smoot to my start. He was a pulmonologist. I was really interested in managing pediatric asthma well. And then the interface of sleep medicine and medicine in general is just fantastic. And so I come to speak today about Down syndrome and sleep apnea, because I really think this is one of the challenges of sleep medicine, but it's probably a space where we can shine. And so we're a fantastic team, and so I want to just reach out to my own team. I'm blessed with a group that Carl Smoot taught to be exceptional. And though they're in the UP, I've yet to find another team who tops them in their commitment to patients and excellence and quality of reads and really commitment to the patient. And so I'll toot their horn. And I really just jumped on the team and joined them. So they're the UP Sleep Disorder Center. We're now Marshfield Medical Center, Dickinson. And Down syndrome is a really important topic for us in sleep medicine. So today I just wanted to make sure that you all understood the reason why you meet obstructive sleep apnea and Down syndrome is because the AAP made a recommendation for sleep evaluation in children with Down syndrome. And the AAP does a lot of exceptional things, but this is one that creates some challenges for all of us in this room. And then I think it's really important to understand the FDA-approved tools to support pediatric obstructive sleep apnea. And in that is probably as important the limited approval and the risks of some of those knee-jerk items that we use for adults when we treat them. And then I'd like to have you understand the risks, complications, and strategies to support compliance. And this is a fun one, and basically comes down to kids like stickers, and stickers are really powerful. And alternatives to PAP in pediatric sleep apnea. And then what I tried to do was to hide some board certification pearls and some recertification pearls for those of us who have to sit for the internal medicine boards as pediatricians and try and pass an examination. And so there's probably a talk into itself that's needed next year as we have to take our sleep medicine boards again. But there are a few pearls, not as many as I wanted to have in the talk. And so we're going to do 4 cases, and as modern medicines progress, we're going to be allowed about 7 minutes per patient. But there's some real important questions when we look at sleep apnea in kids. And so one of the questions is, does poor sleep quality increase a child's with Down syndrome's risk of dementia? And so we know life expectancy of Down syndrome is improving, and part of that has to do with our approach. So one of my questions is, if we would treat sleep apnea and Down syndrome better, would we see decreased dementia in Down syndrome? And so then one of my questions is, and now I'm going to be Italian and a hand talker, but if stage 3 sleep is really these big lymphatic waves, right? So there's this brilliant current, and again, if you're in the room, you're a geek, you like this big current of electrical activity. But if that's providing some sort of lymphatic pulse and clearing the brain of neurofibrillary tangles and debris that doesn't belong there every night, and the reason why people who exercise when they're 84 and perhaps have great N3 sleep and have less risk of dementia, would it stand to reason, and I don't know, that if we granted kids with Down syndrome great N3 sleep and good exercise, that they too could have improved cognitive function? And so could it be that we could take kids, instead of having dementia related to Down syndrome at 20 and 30, if we granted them great sleep with the techniques that we grant everyone else, as challenging as it may seem, could we impact their outcome? And so, and then I really like rules. I do sleep medicine because I like rules, and I like the American Academy of Pediatrics because they tell me what to do. So at 2 months, I give these shots. And at 1 year, I screened for anemia and I screened for lead. But when it comes to what we're asked to do as sleep physicians, when we receive a kid from Down syndrome, I feel as though there's some absence of rules, yet there's really great science. And so why don't we make some rules? Because we like rules. We like 2 missed breaths. We like 3% or 4% rules. And so I just think that as a community, we really need to work together and sit at this table in a team together and do what we do in sleep, which is we all work together to get the patient compliant, to get the data. And if we did that in Down syndrome, these kids would have a better chance at life. And frankly, I just love these little guys. So the AAP made these great recommendations for sleep evaluation of children with Down syndrome. And so there's really clear guidelines that all these kids should come to us. And so I guess I would say, get ready. They're all coming to you. And then I would say, as they come to you, what should we do with them and when? And so I think when you look at what I do, you don't do the same thing for an 18-year-old or a 16-year-old or a kid with autism and a kid who's 2 months who's developing normally. And so I think if you would just join me on the timeline continuum, I can begin to give you some degree of insight as to what I think we should be doing. But as is sleep medicine, it doesn't matter what I think, it really matters what we think. And if we could think well together, I think these kids could do better. And so here we go, medical problems in Down syndrome. And so kids with Down syndrome have a host of trouble. They have hearing problems and vision problems and obstructive sleep apnea. And so 50 to 79% of them have obstructive sleep apnea, which I find striking because I'm always surprised when I study a kiddo who doesn't have sleep apnea and has Down syndrome. So I just think they all should have sleep apnea because most of them do and they're very hard to treat. So I met a great little girl who's a fantastic skier in Kalispell, Montana, where I was at the Children's Hospital of Montana and the Rocky Mountain Heart and Lung Center. And I studied her and she didn't have sleep apnea. And so she was too busy swishing down the hill to need to have CPAP, which was fantastic. But within this is also the other things that we see in Down syndrome. And so I think if all of these kids are coming to you, I think it's really important for you to understand all the things they have, how that ties back into sleep apnea treatment, but also all those things that we need to know that they have so that we don't miss it. And so within that is otitis media with effusion and hearing problems and recurrent infections. And so maybe adenoid timing becomes really important because if we take their adenoids out to treat their sleep apnea, we also improve their hearing, and we also didn't have them needing a hearing aid, or we got them to a great ENT in time to preserve their speech and language development because we did this well. These guys often have feeding difficulty, and maybe that's the space for some myofascial therapy. They have respiratory infections, dermatologic problems. They have hypodontia. So what do teeth do? Teeth create bone. Bone creates space. Space gets made for their tongue. Super. And then we give them a big tongue and very little teeth. And so we already have a mismatch in the tongue size. And so I always say to my patients this way, you've got room for a cot, but you've got a king-size bed. This creates a problem when you fall asleep. And so that tongue is going to end up back in your airway. These guys also have congenital thyroid problems. They have Hashimoto's, hyperthyroid. By adulthood, most or just over half of these kids are going to have thyroid disease. They have intestinal atresias, so the gut segments just don't develop. They have megacolon. They have seizures, and so think about the complexities of seizure management in the lab. Now give the condition Down syndrome, hypotonia, seizures. Put these kids on a host of medications. Now you've got sleep discontinuity from their seizure medications. Now you've got a risk of SUDEP because you have kids who can have sudden unexplained death in sleep, and so we need to know about SUDEP. And these guys have a host of hematologic problems. So we know about the trouble of restless legs and anemia. We know, or you will now, that out in Seattle they described some restless sleep behavior, which really has to do with iron stores. And if our iron stores are met, we have less restless sleep problem. And so anemia and iron deficiency, also common in this population. But within that, these kids that are anemic also have a risk of leukemia, so sure don't miss their ALL, right? Because they have a risk of acute lymphocytic leukemia as well. The interesting thing about these little guys is they also have a lot of autoimmune conditions, so Hashimoto's, thyroiditis, Graves' disease, celiac disease, type 1 diabetes, and alopecia. And so the question is, narcolepsy is not listed on this list, and we're geeks, right? So we know that narcolepsy is an autoimmune disease, and so why is it not here? And so I don't know why it's not here. It's certainly here in Prader-Willi syndrome. And so is it not here because we think they should be sleepy because they have obstructive sleep apnea and they won't get treated? Or is it that we're missing it? And if we're missing it, should we start looking for it? So I don't know that question, but man, there's a lot of questions here we should be answering. And then these cute little guys are my favorite because they've got some atlanto-occipital instability, and they'd all do well if I can enroll them in HIPSA therapy, which is the horse riding program in the UP that they should all benefit from. And so they all should be getting neck x-rays before we load them on horses and improve their tone of their whole body. And then hardest is probably 1 in 5 of these little guys is gonna have autism. And so we've tried to study autistic kids in the lab. It's really challenging. It's very doable, but I guess that's where we're gonna come about talking about some of the tools that we're gonna need to support these kids. So they're beautiful and they're complicated, which makes them my favorite. So congratulations are in order. This is my friend Dawn. She's one of my favorite nurses. Wouldn't surprise me that she has one of my favorite kids. And so she's holding Nick. Nick is 2 weeks old. And one of the things that she wished was that she just got a fantastic congratulations. And so if we could just stop and congratulate folks and realize that they just had a baby. And I have 3 of these little buggers, and I love them all. But before we launch into the medicine, we should just make sure we say congratulations to these parents, because holding a new baby is awesome. It doesn't matter what chromosomes they have. And so I think we should stop and say congratulations and then help families succeed on this journey. So here we are at the AAP guidelines, and so I love rock climbing, and so here's these great steps in what we should do. And so I like, as I get to the edge of the cliff, that there's really clear delineations of what I should do, that I should grab my thyroid, I should screen for celiac annually, I should make sure the kid doesn't have leukemia every year. And then at 2 years, I should make sure that their lead and hemoglobin are okay. And then as a pediatrician, I walk to the end of the cliff, which is where you all sit, which is why it feels, I think, a bit uncomfortable, because I have all the rules, and then I jump off the cliff. And what I'd like to do is just structure that leap. So when a kid comes to you, we don't have any more rules. We have a lot of science, but we don't have the rules. And man, I would love the ASM to put together rules for us as we jump and leap into Down syndrome. And so I guess as you engage in this conversation, which I hope you do, what do you want the guidelines to look like? What should we be doing when? And so as we do our schedule and see our patients, and my question is, what should we be offering families as we do this work? And so here they are, the beautiful patients, many of which have been pictures stolen from the Autism Society. So Noah's 4 months, we're gonna see him first, 7 minutes patient. Leah's 4 years, we're gonna see her with her speech therapist mom. Then we're gonna see Jakey, I learned today that we should advise the didgeridoo and not the guitar. And then we're gonna talk about Nick again. And so Nick is the brick, and I'm gonna weave him into my talk because I think if we do it well, we get more Nicks. And so here's Noah. He is a real sweet kid. He had real small ASD and VSD. It was so small that they felt like he could deliver at our little hospital of Dickinson, except we didn't expect he was gonna come 2 months early, and he did, and we transferred him out. And so in the 4th hour of his life, he developed bilious emesis, which, if you're geeky like me, you know is a rotation often of the midgut that results in this bright green emesis. But in Nick's case, because he's got autism, he had Hirschsprung's disease. So he had a gap deficiency in his gut. So I also want to talk to you again about Dawn and Nick. And so Dawn was amazing to me. And so as I was developing my talk, and I'm a physician who's smart enough to know that nurses know more than I do, and if I listen to them, they'll take me where I need to go. I asked her for some advice on this talk. And so while we're talking about the first little guy, Noah, and what we're going to do for him, I just wanted to zoom you into Nick's world at this moment, because he wasn't well enough to be in our lab yet. And so I think in Noah's case, he's well, and we could study him during the day. He naps. We could get oximetry. We would expect that he has some central sleep apneas, but we could begin to see if there's anything that he does in the lab that would help us understand how he sleeps. And so let's nap him. let's put some leads on this little guy at 4 months. He's really only 2 months, right? So we're going to adjust him. He's only 2 months. And what we should see in the EEG is some spindles, right? Because I'm a pediatrician, so kids roll at 2 months. They also have spindles at 2 months. So spindles should develop in the brain at 4 weeks. And at 12 weeks, they should be there, right? But these kids are delayed, so they may or may not be there, right? So we can see this brain maturation as we look at a kiddo with sleep. So we're going to nap this little guy. And so when we nap him, we can see how much central sleep apnea he's going to have. He's going to have some because central sleep apnea is normal in childhood. There's a board's talk on how you tease apart how much central sleep apnea a child should have. But I think getting the data in this little guy early is important because is he so hypoxic that he's in trouble and he should meet ENT soon? Because while we don't historically take out tonsils and adenoids at 4 months, sometimes kids have so much laryngomalacia, floppy airway, that they need that done earlier. So I think it's okay to study these kiddos in the lab, and I think we're capable of doing it if we decide we want to. Meanwhile, I'm going to fast forward to Nick and my friend Dawn. And so Dawn sent me these pictures, and the other one she sent was a little picture of Nick propped up at 6 months. He's got a little baseball cap on, and he's super cute. And so she said, the one holding me at 2 weeks, the other at 6 months is in June. I had it taken because I thought he was going to die before his heart surgery. I was setting an alarm every hour where I would nurse him for about 5 minutes. Then he would turn dusky gray-blue color and pass out again. And then we do it again the next hour, around the clock. The diuretics and digoxin weren't working. The heart surgery was scheduled for mid-August, 2 months, and he was only 6 pounds and needed to be 10. The congestive heart failure was progressing fast. They wanted him to be 10 pounds, but he was already losing so much weight. I actually called Children's Hospital and asked to speak with a surgeon because my gut was churning. Other lesson in pediatrics is moms are always right, and they'll save you every time. They laughed at me when I called and said that we don't do that. I finally asked to talk to a cardiac ICU nurses. A nurse there told me to trust my gut. If I thought he wasn't going to make it to mid-August, to pack him up, drive him right away to the ER at Children's Hospital where they would have to see him. 4 hours later, we were there. He was baptized, given last rites, meds and blood transfusions, and was being admitted to ICU. He wasn't even stable enough for heart surgery. 2 days later, so he's got an AV canal defect, he came out of the OR pink and beautiful, and for the first time in his life, I thought I might actually be able to see him grow up. They told me if I had waited, he would probably die. So that's what I see when I see my boy, a boy who, from birth, has been determined from birth to beat the odds, to do things they never said he would do. I would love to see the PT that said I should order him a wheelchair because he wasn't walking at 3 years old. I'd love to talk to the insurance people who wouldn't continue to pay for his PT because there was no documented progress. And the whole time, and I'd like to just learn from this doc, I would hear Dr. Herman's words in the back of my head, "Congratulations, you're going to have a boy. The only limits you'll ever have are the ones you put on him." And so I'm going to keep Nick weaved in our story as we figure out what we should do for these great families. So as we talk about that first patient, I think it's really important to understand that SIDS is our domain, right? So if you don't breathe and sleep, that's us. And so I think as sleep physicians, though all you're doing is seeing these infants for sleep, you need to know they need to sleep on their back. 90% of SIDS happens in the first 4 months of life. A fan in the room reduces SIDS. A pacifier reduces SIDS. Breastfeeding reduces SIDS. Premature babies have increased risk of SIDS. These kids with congenital heart disease and hypotonia have increased risk of SIDS. So I think we have to be really prepared to counsel families. And so while they might not need CPAP, we can suggest the strategies that help him. The other really important thing in this population is these are the kids that have BRUIs, right? So brief unresponsive events, which are the old ALTIs, because we have to rename everything in medicine just so we keep up. So the old ALTI is now the BRUI. And so we need to understand when a BRUI is a risk for a kiddo and when there's something like GER that we could do. And so just to be a sleep medicine physician or to do what you do, if kids are having episodes, GER is very common, right? And so medications work for adults, but a position of 30 to 60 degrees is really effective at treating reflux in children. And then what you should know is we tell everyone to breastfeed, but breastfed babies have the least viscous meal imaginable. So they got no tone, nothing to hold it there. And then they have this thing that kind of free flow, and position can help that food stay where it belongs, which is why Infamil AR or other rice starch proteins exist, or we can put rice into the formula to keep the food where it belongs. But when these guys are really little, they're designed to come through the birth canal, right, and not breathe. So they'll do these very scary episodes, and you just have to counsel parents that this is terrifying, but it will get better because they won't think that they're going through the birth canal anymore. And then as they get older, you begin to see reflux. And so I think it's really important to understand, how do we treat reflux in these little guys? So while it's not CPAP yet, it's SIDS, it's reflux management, and it's understanding bruits and what you might be missing. So I guess I would advise SIDS, bruit, and management at that age, but I'd welcome all your input as to how we would structure those guidelines in the first 1 to 2 years of life. So the next patient that we have is Leah, and Leah is blessed because she comes in with this brilliant woman who's a speech therapist who hadn't thought about her tongue tie release, but recently went to a conference about tongue tie release and the importance in managing sleep therapy and obstructive sleep apnea. And she also learned about myofascial therapy. And so NICE is these guys should have a team of PT and OT and early on, and we can engage with them to get these services. So all these little guys with Down syndrome, right, could benefit from myofascial therapy, and they already have the team to do it. So just understanding that we need to connect and recommend what they have address their sleep apnea is really important. And so, this is where the skilled ENTs really need to come into the life of these little guys. And so these kids, this little one already had recurrent otitis media because their immune systems in Down syndrome are not that great. And then mom had debated an adenoidectomy, but she was just hoping to not have to do a major surgery and have bleeding risk. And so she had put it off. So now we're on the 4th set of tubes. And so now when we studied this kiddo, we saw severe sleep apnea. And so the kiddo had an AHI of 32. And so now she was ready for adenoids. And so then the question is it also time for a tonsillectomy? Her BMI was low, and so she was a great candidate for an adenoid and tonsillectomy. So then the other part of the management of this kiddo, and probably this whole chapter of life, is to understand that tonsils and adenoids are going to get big relative to the skeletal structure between the ages of 4 and 9. And so we have to prepare ourselves that if tonsils are big, they might get bigger as the skeletal system doesn't. And so those tonsils and adenoids might, in the next 5 years in little Leah, outpace her skeletal structure growth. And so this is a really important time to engage our ENT. And frankly, you can't, if you really have sleep apnea, you can't do it without an ENT. And so the other piece of the puzzle is when you think about how you study kids, right? You study them and you're measuring hypopneic events. And so hypopneas are desaturation events. And so if you manage their asthma well, then they desaturate less. And so asthma control, allergy control is really critical for sleep apnea management. So there's risks of CPAP, but there's not risks of Flonase and corticosteroids. There are from a growth standpoint, but relative to sleep apnea. So it might be that the answer is to learn how to manage asthma well and allergies well. And mom wonders how important this nasal spray is. And so I'm a sleep doctor and pediatrician. I call, fluticasone nasal spray CPAP to go because you're done. And it does. It dilates the airway. It keeps things open. It decreases your risk of sinusitis. So I recommend for the CPAP to go, and then just make sure that we're doing asthma control tests to manage the child's asthma well. And I probably would advise against living with the cats that you're allergic to. And so why not CPAP? So it's not FDA approved until kids are 30 kilos, which is 66 pounds, which makes a whole lot of time that the FDA tells us that we can't use this treatment for kids. And so the risk of CPAP, though it's really cute in the picture, is this mid-face hypoplasia. And so I think the biggest and most fun thing about treating sleep apnea in childhood is there's a potential done right that you take a kid to adulthood and the sleep apnea is gone. And so I love being a pediatric sleep doctor because if we do asthma well, if we do allergy well, if we get rid of your tonsils, it could be, if you maintain a healthy weight and lifestyle, it could be that you grow up to not have sleep apnea. And so one of the risks is this mid-face hypoplasia. So I'm blessed that Dr. Carl Smoot, who was brilliant, thought we should train at Stanford School of Sleep Medicine, where Christian Gibno was doing a lot of this work on facial development and CPAP. And this is his article where he found that when you brace the face, so if you think about what we do with orthodontic work, we're bracing the face to get more room. When we treat with CPAP, we're bracing the wrong way, which is one of the reasons that we'd want to avoid CPAP if we can. Now, when we talk about CPAP in kids, we have to worry about aspiration, about creating pressure, and kids are pukers, right? So every day in my office, kids are puking. And so we don't necessarily want a full face mask to force that acid and risk aspiration pneumonitis in these kids because we're forcing pressure into the airway. And so nasal masks are mostly advised. However, sometimes kids just can't tolerate that, and they do well with a mask around the nose and face, and that's a conversation with the family to recommend what they do. These cool full face masks, like you go scuba diving with, are also excellent because they wouldn't kind of affect this mid-face like this. So here's the rules. There's a soft rule on 7, but there's a strong rule on less than 30 kilos. And so really less than 33 kilos, which is 66 pounds, which can take a long time, like 11, 12 years when you're a skinny failure to thrive kid or you have chronic illnesses. It's a long time before we're allowed to put CPAP on the face of kids. And so the nice thing is the nasal cannula is an indication, has an indication, and addressing the hypoxia in this way could be beneficial. And so next is going to be 12-year-old Jakey. He's autistic. That's a talk unto itself. He has a risk of advanced phase sleep pattern. The recommendations from the AAP are to screen these guys at 18 and 24 months. He had terrible self-harm, and so he's on risperidone for behavioral management, and this has resulted in the 35K weight gain. The nice thing is he's old enough that CPAP is an option if we can get him to tolerate. And so this is the skinny on sleep apnea in kids. Do everything. You have to address the nasal airway, the oral airway, gas exchange. You need to avoid smoke exposure because it's a secondary risk of sleep apnea. Sleep position matters. Asthma and allergy control matters. We need to stent the airway, treat hypoxia. We need to look at behavior modifying agents that cause weight gain. Pharmacology in sleep is its own talk. As you do this work, we need prizes, expectations, and understanding for kids. Medical nutrition counseling works when the alternative is CPAP. For those of you who get these kids in the lab, COBAN, TAPE, parent advocacy, going in, committed to getting this study done and having a family member know why you're doing it will help you win. You can't care about someone's kid more than them. And so if they don't care about their kid as much as you do, you'll never win. But if you have a committed parent, you can get the work done. To this audience, not all kids with OSA have ADHD, and kids can have ADHD and not OSA. And so please know that ADHD is a treatable condition that we can treat, and it's not just about sleep apnea. So I think that's just misinformation for the sleep community. So it's important to have these kids sleep well because it impacts attention. But there's some kids that sleep well and still have ADHD, and we have medications to treat them just like we have CPAP to treat sleep apnea. And so neurodevelopment matters, hypoxia matters, growth occurs in stage 3 sleep, so it's really critical that we get these kids to that stage. The endocrine axis is really at play at Sleep and Life. Give these kids expectations. The kids that do the best are the ones that have chores and expectations in the home. Please now know about CPAP and mid-face hypoplasia. Also know that there's a window of time where there's a growth plate in the mouth where you can expand by rapid maxillary expansion and give yourself some airway. And so don't miss that window of opportunity to give a kid an airway and open up a suture line in a pretty non-invasive way, and mood and sleep. So I'm just gonna close with Nick the Brick. And so this is Nick. He's couldn't walk at 3, but he's swimming for the USA team. I have a Nick the Brick shirt. And so he had apnea at birth. He had his tonsils out and his adenoids. Adenoids came out super early because he was having so much trouble. He developed some pharyngeal insufficiency, but it resolved his bruits and his altes. He had a second set of tubes, some hearing aids, and tonsils came out at 2 to 10 months. He had severe sleep apnea. CPAP failed initially. We did use a nasal treatment. His HI dropped to 8, and he did have at 5 years a plan for a future rapid maxillary expansion. Grandpa got CPAP when he was between 9 and 12, and that really helped us because Grandpa wore a CPAP and he wore a CPAP. The RME got placed. Medical nutrition counseling came into play. He started playing on multiple sports teams. He was a football favorite, and the crowd went wild when he got announced. And in the teen years, he rejected his PAP, got weekly calls from the nurse, did develop some mid-face hypoplasia. And Dr. Sonnenberg were just talking about the hypoglossal nerve stimulator, and that's where his family would like to go next, but that requires adulthood, but should it, when we make our guidelines together. And so I just would like to reach out to you and just thank you for owning obstructive sleep apnea and Down syndrome. Stay committed to these kids because it matters, and just thank you for doing what you do. And man, together we could put something really spectacular together for these kids. So thank you.
Got one question that came in on the Slido, and I think you got to this in the end, but, and I forgot to do this, but let's just repeat the question so we're close to the microphone. How soon do you start PAP in children with severe OSA and velopharyngeal insufficiency?
So my answer is as soon as the insurance company will let you if it's effective. And it depends how severe. And I try and treat these kids. And so what you know is that usually these kids are desaturated to 64%. And so if you can come up with a treatment that takes him to a nadir of 92% in an AHI of 54 to 7, why wouldn't you? So I think you start trying. Now, can you is the bigger question, right? So how soon? I mean, they should be 30 kilos. But our little guys that are hypoventilating, right, we put them on CPAP and we try and treat them. So I think you bring them to the lab, you try and see if you can get them treated, and if you can treat them and get data that shows you made them much better, then do it. And so I would argue as soon as you can. I have a little catchphrase that I use to try and argue with insurance. I had a bunch of hospital attorneys helping me bless my catchphrase so that I could talk to the insurance company, and I figured out what Apria wanted, and I figured out what Lincare wanted, and so I have a phrase you can steal to try and get these kids what they need.
And then two more that came in. How about an age or weight for non-invasive ventilation or BiPAP?
Yeah, so these kids, so generally the non-invasive ventilation kids and the BiPAP kids, right, are your hypotonic kiddos. And if they're hypoventilating, they have terribly high CO2. So if you take these SMA kids, they need to be ventilated or they will be sleepy and not functional. And so those kids are a little bit easier to get approved. And so if those kids are sick enough, as soon as they can tolerate the treatment, and some kids have to go home on BiPAP from the hospital. So there's really, I mean, there's children discharged on BiPAP, and that's the only way they get to go home. So we know that we can give kids at a very, very young age BiPAP.
And this might be a typo, high flow.
Yeah, and so someone asked about high flow nasal cannula. I think it's brilliant. And so I think that high flow nasal cannula is a great way to avoid mid-face hypoplasia. And we know if we can, and again, I love this day because all the answers are sandwiched around me. I don't have to do as much work because you're all doing it for me, but there's a great talk coming up about high flow nasal cannula, and that pressure is a great way to ventilate a kid, and it avoids mid-face hypoplasia. So I think high flow nasal cannula is awesome.
Great.
Thank you, guys.
Thank you.